So my name is Dr. Teresa Smith. I feel like I haven't had a chance to meet you all, but I'm one of the psychologists here in DBP. And I was a LEN trainee, gosh, in 2017, I think, and then worked with one of the SEBM groups. And I think one of my group members' moms might be here as a family rep now. Donna Brinkman, are you Amanda's mom? Awesome. Okay. Well, it's so nice to meet you. Amanda is amazing. So
Thank you.
that's fun to already see some familiar faces. I know last week you guys started on just like touching on some of the, comorbid mental health disorders that go along with developmental disabilities. And today we're going to dive into it a little bit more and talk about specific disorders as well as treatment and then some systems levels issues to think about and where you guys can really come in and maybe make a difference. Um, Before we get started, though, I know they talked about last week with you all that some of these topics can be sensitive. Mental health is a personal journey for a lot of people, and so we recognize that and want to make space so that yeah, so we can call it co-occurrences. That's totally fine with me. I think you'll hear it in all different ways. Sometimes it's comorbidities. And so,
Yeah, I just
however,
know with the social perception of it, and that disability a lot of times is linked to sort of physical or mental death, then calling it a comorbid rather than a co-occurrence unintentionally puts that sort of on there as sort of the idea of the word morbidity being something that we think of also with death.
yeah, absolutely. I love that perspective, Jason, excuse me, and appreciate you sharing that. Sometimes I get wrapped up in old ways of thinking and using language, and I recognize that language is so important. So I appreciate you sharing that. Before we get started, like I was saying, also, we just want to be sensitive to mental health and know that people may be on their own personal journey with this. And so, if you ever feel like you need to reach out to somebody afterwards, we're here as a resource and can provide resources for you. Um, we try to stray away from talking about a lot of personal matters within this platform just so that we can kind of get through the material, but also want to recognize that we know that mental health is personal for everybody and we all have our own mental health and mental wellness to manage. And so with that being said, we're going to start with a wellness activity first. I know Pat led you through one of these last week. And so this will focus more on breathing exercises and how you can use that to relax and calm your body. Um, I'm specifically using the app Calm. Have you all heard of that before? Just raise your hand if you have. Okay. So it can be fairly expensive. I actually used to pay around $70 a year for it, but if you are an employee at the hospital, you can get it for free. So all you need is an employee ID and you can use it for free. I think that's just really important to know that those mental health resources are out there because Calm is an amazing app and has a lot of great wellness activities. The one that we're going to be doing today is for children, but what I found as a child psychologist is something works well for children. It probably works well for adults as well. And it's a little bit more brief in time. So we're going to go ahead and get comfortable in your seats. Feel free to turn off your cameras if you feel like that would be more comfortable as you're participating in this exercise. And I would really encourage you to try to participate because it's pretty amazing what just a couple of minutes of deep breathing can do. So let me go ahead and start this. And then James, if you could just give me a thumbs up to let me know that you can hear it, that'd be great.
Hi, my name's Tamara, and I'm going to teach you an exercise called a blowing candle meditation. It's 3 minutes long, so give it a try and see how it feels. Find a spot to sit, either on the floor, on a chair, or anywhere that feels comfortable. Rest your hands in your lap or on your knees, and when you're ready, close your eyes. Keep your back nice and tall like a mountain, but make sure you feel relaxed. And just notice how it feels to relax in a still quiet place. Now take a slow, deep breath, and when you're ready, blow the air out slowly, like you're blowing out a birthday candle. Blow as slowly as you can. Take another deep breath, nice and slow, and blow the air out again. Try this a few more times on your own now. Breathing in and out, blowing out the birthday candles. Good. Keep your breath nice and relaxed, blowing in and blowing out the birthday candles. Try it again just a few more times. Good. Now let your breath relax so it feels natural. Just notice how you feel. Then, when you hear the sound of the bell, gently open your eyes. Wonderful job concentrating on blowing out the candles. Know you can try this meditation anytime. Congratulations.
All right. Well, I appreciated seeing that people turn their cameras off. I think that means that you participated. I'm curious how that went for people, if there was anything that was beneficial or anything that you noticed that was challenging during that deep breathing exercise. I know typically when people first start these, they tend to be a little bit more difficult as our minds get easily distracted. So just wanted to check in and see how your experience was with that.
Before the exercise, I had like a ton of tension in my shoulders, which is what I
Yeah.
get when I'm stressed. And I feel like it eased a little bit. That
Oh,
was
I'm
nice.
so glad. We got some comment in the chat too that it was very calming. And I think we forget how these small strategies can make such a big impact. You're like, oh yeah, I'll do that later, or I'll try that later. And that's why practice is really important. And we really try to stress that to children and their families, that you want to practice these strategies often in times where you're not feeling stressed, so that you can use it when you are feeling stressed and it just feels a little bit more natural, because it can be challenging. I know I felt my mind wandering. I was thinking about things I needed to do for work, reports I needed to get caught up on. And so I appreciate you sharing your experience, Caroline. Looks like we got some others. Yep. And it's geared towards kids and the language and length. And so that's the great thing about Calm too. If you are a provider and you want to use this with your patients, you can. So they have it for that age group was 3 to 5. They also have it for 1 to 2, school age, and adolescents. So it's developmentally appropriate for who you're trying to gear it towards. I'm so glad you guys enjoyed that. Okay, well, let me pull up my screen. And James, if you could just give me a thumbs up when I get this going and let me know that you can see it okay. Oops. Try this again. All right.
Yep, I can see it. And actually, I think I have the first couple slides, so I can go ahead and.
You too. Yeah. Do you want to talk about what we're going to be
Sure.
discussing today, James?
So last week we kind of ended off talking about a couple of co-occurring disorders, so things like ADHD and other disruptive behaviors. So today we're going to start off talking about some of those other most common co-occurring mental health conditions, such as anxiety and depression. And then after that, we're going to be talking about some of the referrals or treatments that are appropriate for our population if they have any of those difficulties with anxiety and depression or some of those other conditions that we talked about. And then lastly, as Dr. Smith said, we're talking about those kind of system level barriers that can make accessing services more difficult for individuals within our population. So I think we can go to the next slide.
All right, hold on once. Oh,
we're at the very beginning.
James, can you hear me?
You can just go over all this stuff again.
Yeah, you guys didn't know you're gonna get round 2. Hold on one second. Sorry, I'm not used to working in Zoom, and so I am just gonna pause this really quick. And get up our day 2 poll. Thank you for being so patient as I do this. All right.
There we go.
All right, James, it's all yours.
All right. So the first co-occurring condition that we'll talk about today is anxiety. And just kind of to start off, because I feel like oftentimes what we see in psychology is a lot of disorders or lots of names for disorders, and the difficulties that individuals face have kind of become common vernacular and are used in everyday situations to not really describe like what we see as psychologists. And so kind of a classic example of this is if someone's really neat and organized, you kind of just toss around, oh, it's OCD, or they have OCD. And what we're really talking about when we're talking about mental health conditions are that these are disorders that are causing significant impairment for the individual. But that being said, a lot of those difficulties do exist on spectrums, and they can range in severity and intensity and the level to which they interfere with functioning. Anxiety is another one of those disorders where us as clinicians have a kind of specific set of criteria for if something's a disorder or not, that DSM that we talked about last week. But that doesn't mean that you can't still be anxious or have anxiety even if you don't have an anxiety disorder. So this is presented a number of different ways, but as a whole, anxiety is the most common group of mental disorders for just the population in general, and then also for children and adolescents. And so in children and adolescents, it's actually the second most common diagnosis after ADHD. And it's about 10% of children and adolescents have an anxiety disorder. And then that prevalence increases with age. And so oftentimes as responsibilities get larger and as you're starting to be in more and more situations where you're supposed to be independent or kind of managing for things yourselves, or you are facing new challenges that come with aging, there's lots more opportunities for things to impact you that way. So we do see this increased anxiety over the course of the lifespan. And as I mentioned, anxiety it's on the spectrum, right? So it can be at the kind of lower end of the spectrum. It could be mild and occasional, or it may be really severe and maybe out of proportion to what's happening. And sometimes anxiety on that lower end can be helpful, right? So let's say Dr. Smith and I had zero anxiety whatsoever about this presentation, probably less likely to prepare for it or make sure that we have our slides in order. And, probably not going to make sure that we know all the notes. We just be maybe reading off the slides and being really lackadaisical and, who cares, right? A little bit of anxiety, a little bit of, I want to do well. I want to, look good in front of others and perform my best is helpful. It motivates you to really kind of push yourself and try hard. But let's say that anxiety was ramped up to 100, let's say I was so nervous and worried about giving this presentation that I couldn't prepare because I was so worked up thinking about what was going to happen or what was I going to say. And I stayed up all night and I couldn't fall asleep. So I was exhausted today and I never got my preparation done because I just spent so much time worrying, or maybe I didn't even join today's meeting because I was so worried that I might say something wrong or make a mistake or mess up the slides that I didn't even attend today's meeting. Now that anxiety is starting to interfere with how I'm doing. I'm not able to do my responsibilities in this case. It impacted my sleep. Because of that, my mood's probably impacted even more so because I'm tired, or more tired, more tired, I should say. I'm always tired. And so now we're getting to that range of a disorder. It is impairing, it is interfering, it's causing a lot of extra kind of stress. And so there are lots of different ways that people cope with anxiety, no matter where it is on that spectrum of intensity or severity. So kind of opening up to everyone, what are some ways that you guys, kind of cope or manage feelings of worry or nervousness, kind of at any point on that spectrum? Uses your journal.
I guess
Excellent.
the way mine sort of goes, because I'm generally predisposed and somewhat social anxiety, it is a lot of times when we're told, like, and this goes into like other things with OCD and stuff, that this is what's wrong with you. This is what, and that we sort of see it as not natural. The problem what it becomes is when it becomes tough enough to where it's not functional. So being able to realize that anxiety, and when you're told that you're wrong or that the way your brain works or things is bad, then it can also cause more anxiety because you want to try to never be anxious, which is not possible.
Yeah.
So also realizing that anxiety has its purpose and it does that, or some of the other traits I have its purpose and its strengths and stuff. It's just making sure that I don't heavily rely too much on one thing or not another in a way that makes it so maybe it isn't effective, or it also traps me in some ways.
Yeah. So
Sorry.
Jason, is there anything that you do that helps you kind of, or prevents you from going down that kind of spiral of worrying about others, or that helps them not get in the way?
I mean, I think there's some physical stuff I do, like walking or watching things I like, but I think it's also trying to be mindful and trying to remember, just because I have are autistic or I have anxiety or that I have OCD tendencies, that doesn't mean that it's necessarily bad in of itself. It's just making sure, I had a therapist who I was talking to who said our greatest strengths can also be our greatest weaknesses. So, sometimes I think we think about all this stuff of like being autistic or having some anxiety as in some ways just being a weakness, or that it's so like being able to realize like there is reasons that I have it and it's not necessarily just bad in and of it itself, but when it really makes it hard for me or it really makes it hard for others around me, and trying to keep that mindful, because I think sometimes I would get anxious because I was trying to fix everything or I was trying to be normal, and then I would cause more anxiety because I was like, I shouldn't be anxious at all, and just trying to be mindful. And then also having some strategies of like, if I'm in a thing, like maybe sometimes like if I'm really heightened, like I have one anxiety medicine, essentially if I don't have time to walk or do a lot of exercise, or maybe it's watching something that sort of is interesting or destimulating sometimes, depending on if the so just figuring out different, or listening to music or sort of different things. So it's like a combination, I guess. Sorry, I don't mean to.
Yeah, no. And
Jason,
I think,
thank you. Oh, James, is it okay if I say something in response to Jason real quick? So Jason, I really appreciate your perspective. And I just wanted to share something as, from the psychology perspective that we often do is we want people to own their anxiety. We want them to say like, I have anxiety, because a part of saying that you don't have anxiety or ignoring that is a part of the avoidance that James is
Yeah.
talking about. And we know that can just make it grow and get bigger and bigger.
Mhm.
So we want them to own it, but then also realize that it's not something wrong with you. It's almost something outside of you that's happening to you. So James is
Mhm.
going to talk about that a little bit later, but you're hitting a lot of nice take home points, Jason, that James will get to.
Thank you.
Yeah, I was going to say everyone kind of uses a variety of strategies themselves, and then within people or across people, those strategies differ. That's also some of the other things people have mentioned in the chat were like exercise and journaling and reflection, running the half marathon. That is the if that helps you cope, then as good. See, for me, that would give me more stress running the half marathon. But it's individual, right? It's different for each person. And it varies in effectiveness. Avoidance just so happens to be the most kind of common strategy that people use because it's really effective. If I don't do that thing that makes me worried, then I don't have to worry, right? So say you're afraid of bees and you just don't go outside, right? It's really effective.
Oh, sorry. I forgot another strategy, which is I try to make sure that I space out time and give myself mental breaks and making sure that I'm not trying to do too much at once. Otherwise, then it heightens my brain sort of activity.
Yeah, no, Jason, that's a great strategy. That making things manageable is really important. But importantly, when we're talking about strategies, we want these things to be ways of dealing with that anxiety rather than just getting rid of it. We're trying to manage it and face it to help reduce some of those worries. So anxiety is also very common, specifically within autism spectrum disorders. Around 40% of individuals with autism also have a diagnosed anxiety disorder. And the most common ones are things like social phobia or social anxiety. So being really worried or really nervous about what other people think of you and maybe embarrassing yourself in front of others. Separation anxiety is also very common. So this is fearing that something bad is going to happen to either yourself or a loved one, like a caregiver, where you would never see them again, you would never be with them again. Panic disorder is a fear of having panic attacks. So not wanting to be out in public because you're worried what would happen if you had a panic attack. Would you be able to escape? Would you be able to use strategies to help calm down? And then specific phobias, these are those kind of classic, this one thing that just scares you to death, right? So it could be something like dogs or insects or spiders or snakes or the dark, those types of things where that fear is really out of proportion to the actual danger that that thing faces to you. So these are the most common ones. And there are a number of reasons why anxiety is so prevalent in autism spectrum disorders. And a lot of it has to do with some of the difficulties that are associated with autism spectrum disorders. And again, the level of difficulty that you have with these types of anxiety symptoms is also kind of associated with the level of difficulty the individual may have with some of those autism spectrum symptoms. And everything is kind of existing on this continuum. But some of the reasons why we do see increased rates of anxiety in individuals with autism are some of those difficulties expressing themselves, whether it's verbally or non-verbally, or kind of having the understanding to be able to express how you're feeling or what you're thinking about. Difficulty coping with strategies. Oh, Teresa, am I going back oh, there we go. All right. Also, at times, difficulty coping with change and new things or new situations. Having this kind of preference and need for predictability and sameness in what you do. Having some difficulty understanding different social expectations for others. Having a hard time with situations because it's hard to understand them, or having some difficulty flexibly thinking through different situations or through problem solving. Sensory sensitivities as well. So things that cause discomfort and aren't comfortable to, whether that's physically or maybe internally. Those are things that we're going to want to maybe avoid or not want to put ourselves in because it doesn't feel good. We don't like feeling that way. And then lastly, having those feelings of maybe inadequacy, not fitting in with your environment, not fitting with others in school or at work, not feeling like maybe you're not doing as well at something. So all these things can contribute and result in pretty significant anxiety and worry. All right, so how this anxiety presents in individuals is going to differ based on each specific person and some of the challenges that they face or some of the ways that they think through things. But some common ways that we see in clinic and in the treatment groups that we run of this anxiety in individuals with autism are things like avoiding new situations or new environments, withdrawing from those social situations, especially if you're worried about that negative social evaluation from others, having a hard time with those changes in routines and wanting everything to kind of be set in stone and have structure and have rules, and that sameness and that consistency. Having some like escape routes, the ways to get out of those situations that are causing fear or anxiety. Maybe seeing an increase in some of those repetitive behaviors that you see in children, individuals with autism. Sometimes the sensory components of those behaviors can be calming and can be soothing. So when the person's feeling really anxious and really worried, those behaviors are going to increase as that coping strategy. Also, some difficulties with irritability and explosiveness, and those quick changes in emotion. Remember, we talked about last week, individuals with autism sometimes have differences in the way their brain is functioning, and oftentimes those differences happen in the parts of the brain that control emotions and control things like problem solving and thinking through things. And so if your brain has a little bit more difficulty with those aspects, your emotion regulation is going to be a little bit different as well. It may be really quick to become very angry real fast, kind of going from 0 to 100 when things are scary or are nerve-wracking or are different. And so that's why we see oftentimes a lot of these disruptive behaviors as well.
All right. Well, James, thanks for bearing with me as I'm getting these slides figured out, and for all of you too. I appreciate your flexibility with my technology skills. So I'm going to talk a little bit about depression. So as many of you know, this is a mood disorder. And so how it typically presents is a pretty low mood that's consistently low. So for several days or more, oftentimes individuals feel worthless. They don't find pleasure in the things that they used to really enjoy. So, maybe somebody who really enjoys to run, and that's an activity that they like to do a lot of the time. And all of a sudden they're not running, and there's not really a reason for that. So that's kind of an example of that. Oftentimes there's thoughts of death, not always, but sometimes. And this might be fleeting thoughts like, oh, I just wish I wasn't here anymore, or more serious like suicidal ideation. This is also fatigue. So individuals with depression feel really tired. It's hard to get up, it's hard to get going, it's hard to get through the day, which can obviously also lead to trouble with concentration. When you're tired, you're not paying attention, and it's really hard to concentrate. One of the key things that we look for, especially in children related to depression, is behaviors. And so this is oftentimes a change in appetite. So maybe a child is now eating a lot more than what they used to eat, or perhaps they're eating a lot less. This could also be changes in sleep. So maybe a child that has difficulty getting up in the morning, wants to take naps a lot, or on the other end is having difficulty sleeping and is kind of up all night. So this is how it typically presents, but we know that this can look different for children and individuals with developmental differences. And so I just want to hear from you guys of any ideas of how you think depression might look in individuals with DD.
I would suspect that, kind of like Dr. Smith and Jason talked about last week, the confounding factors like in diagnosis, that medication effects and things like that might play a role in discerning what's a symptom of depression and what might be a side effect of some of the medications they may be using. Yeah. Medication is really important to look at, as well as any other medical differences that might be happening.
because we know there's a lot of physical symptoms associated with depression. So that fatigue, the difficulty concentrating, those kind of things. So it is important to look at the body and the physical components of that. Specifically, individuals with DD, depending on kind of where you're at and your functioning, may have more behaviors. So we might see the depression more than them be able to say like, oh, I'm worthless, or I'm having thoughts of death. So they might cry easier. They may be less likely to engage in the social or self-help skills that they used to do. So maybe this is somebody that's really just struggling to shower every day when that used to be fairly easy for them. Oftentimes what we see in children and adolescents and individuals with DD is irritability. So somebody might kind of snap at you or have a temper tantrum, and there's not really a clear reason. It's hard to kind of determine what the trigger was. And so that's something to look into. Like, is there something going on with their mood? Are they appearing irritable more often? And then, like I said, the difficulties with appetite and sleep. So if your child's like losing a lot of weight or gaining a lot of weight suddenly, those might be things to look at. I think especially for individuals with autism, the social withdrawal may be there, it may not, but one of the things to really look at is we know one of the cool things about autism is that people have really specific interests and there's things that they really, really like. And it's I think a strength of people with autism. So if you see somebody with autism that has a really strong or specific interest, and then they're not showing interest in that thing as much, that might be a cue to you that they're struggling with mood or depressive symptoms.
How does
And then I
that
saw
work with somebody, because there is some things about it with even with looking at autistic people, that there's people who are autistic and who have longer sessions of this is like what I always like and this is like what I do all the time. But then I'm in the sort of person who's an autistic person, which I'll go into many obsessions, but then I'll get bored with it and move on to something else.
Yeah.
So moving on to something else, would it just be that it seems like there's no interest that they're looking at?
No. So Jason, that's a great question. So this would be like, you're just not showing interest in anything. Like you're not moving on to the next thing that you're interested in. Yeah, I'm glad you clarified that. This would be really a loss of like interest in most things. So a lot of times people with depression will say like, I just don't want to do anything. I want to lay in my bed, like, or they'll do activities that maybe require very little effort, like watching TV. And that's kind of what they seem to do. There's just not a lot of interest in general. And so switching from one really strong interest to another would not be indicative of like depression, for instance.
Just because I know sometimes, and for sometimes I would be like, oh, well, it's, because I think we sometimes think of it as a one obsession that somebody's like, always, that's the only thing they want to talk about is some of the, sorry, Christy, you want to say so?
No, I was just going to say this brings up like a lot of reflections and memories for me, because there were so many times where when I talked to families about an adult, that depression often was not thought about, even though they would see all of these things going on. And oftentimes with those transitions from school or from jobs or any of those things, those transitions were so hard. And yet I do feel like the field in general underestimates the conversation of depression.
Yeah. Oh, Christy, I love that perspective. And I just love seeing all the different LEN trainees this year. You guys have such cool, unique disciplines that weren't in my training class. So it's so nice to have the adult perspective represented here. I know I live in the kid world. And so that's how I think. And so I really appreciate that adult perspective. And I think you're absolutely right. Like those can all be really indicative signals that there's a difficulty with depression, and something that should be strongly looked into, because just like anxiety, we know depression is oftentimes an internal state. So it's something that you're experiencing on the inside. And so if you have difficulties expressing your emotions or sharing what you're thinking or feeling, it's going to be hard for people to know. So it's really good to look for these behaviors instead.
Well, and I think there's sometimes autistic people also do. I mean, depending on for some people, that people do in some way say it. It's just learning how people also talk about it in some ways. And I
Yeah.
mean, I know for some autistic people too, a lot of times you're aware of what's going on, and that there's something or that you're different or something. Because some of the stuff too with going with anxiety is that you're overwhelmed with the amount of information, because you're the way that, I mean, even though you can filter some things better, other things your brain doesn't have as much control over filtering, sort of things. So especially with like sensory, it's like a Halloween, it's like a haunted house, sort of, because it uses some similar strategies. It just goes, or if somebody gets older. But sorry, that wasn't the point. But I mean, just also the awareness too of, I think sometimes we don't, I mean, I know we talked about it with with even just at the beginning of this presentation, James and Jen talked about how they didn't even think people with disabilities could have with intellectual and developmental disabilities could have mental health issues, because they weren't human enough or didn't have the range of emotions enough to be able to. And I still think that and that's why I get with the co-occurrence of languages stuff, is because I think there's still this assumption that, oh, well, it's not always picked up by groups of people with intellectual and developmental disabilities, that they're perceived as different or they're treated different. And I don't know if that's 100% true. I don't know if everybody can express it, just because it's hard to express a lot of things for a lot of people.
Yeah, absolutely. And you're absolutely right, Jason. It's important to figure out the word that, or the language people are using around the feelings that they're having. And oftentimes, and James will talk about this in a little bit when we talk about treatment, we try to figure that out with kids. Like, what is the word that you use for anxiety? Because oftentimes they're not going to use anxiety, right? Or what's the word you use for feeling sad? Because sometimes that word feels hard to say. And so the language around how you're talking about it is really important. So I appreciate you sharing that. And I think you're absolutely right. Like, anxiety and depression is difficult for people with and without disabilities. Mental health is hard. And when you're struggling with it, it can be a difficult journey, and it can be difficult to express no matter who you are. Why, again, it's really important to look at some of these behaviors, and if you're seeing them in anybody, to kind of check in.
And Teresa, I'm not sure if you're able to see the chat or not, but Angel had a question about how providers communicate that information with family members of individuals with IDD, since there are so many different warning signs across people.
Yeah. So as far as like communicating, if there's a concern, is that what you mean, Angel?
I think more so like prior to there being a concern, how do we make parents aware that there are different warning signs? So they're not looking for it, maybe just like the typical, because it's presenting different if they have a child that has an intellectual or developmental disability. Does that make sense? So that we're not waiting too long or not getting that information to parents until it's already developed and we don't have the coping skills in place.
Yeah. And I think you're hitting on a really excellent point that we're going to get at later in the PowerPoint. And, just thinking about this from a systems level, and what are we doing from almost like a public health perspective when we're talking about mental health with parents of children with DD, and what is it that they should be looking for? Because I think it is something that we're still learning about, and is not talked about enough, but we're getting better at it. So, PowerPoints like this, some of the things that James is going to talk about in terms of treatment, some of the things that are going on at the hospital, we're getting a lot better at it, but there's still room to grow in that area. I think one of the most important things that I can stress to you guys is just, again, looking at the behaviors and if there's a change in somebody's baseline functioning. So, if Johnny...
I have another question, because it was the opposite. I had something, because sometimes autistic people can also be very expressive in some ways, and very literal. So I've had times where I've told somebody I'm going through a hard time, or I'm really I'm depressed and sort of something. And then they're like, oh my God, he must be suicidal. And then they go to my parents, like, he must be on my own guard. I don't have which feels like, he wasn't listening to what I'm saying, because I can be really sad and not necessarily,
Yeah.
and feeling like too, like it's, I don't know, like, how do we also make sure to work with that person as well? Because I know, obviously this is tough, and agencies and people have like things that they have to go through, but it sort of felt like, I was trying to be forthright and honest, and I was having a hard time, and and it felt like they were like worried I was about to kill myself, which,
Yeah. Well, I appreciate you sharing that, Jason.
Sorry.
No, you're okay. I appreciate your perspective and you sharing. I get so I will self-disclose, I have ADHD and I get very distracted. And so I'm going to finish Angel's question and then get to your comment. You're okay. It's okay. So for Angel, what you were saying is I think that really we're looking for the behaviors, and we need to educate people more generally about mental health behavior concerns, and if there is a change from baseline. So if there is a lot of crying, if there is avoidance of things you like to do, if you're sleeping a lot more or eating less, so those things. So focusing on the behaviors. And also it's hard to assess for some of these things. So that's why people like James and I go to school for a ridiculous amount of time, so that we can learn about these things and really assess the severity and, where the intervention and at what level it needs to be. And that gets to your point, Jason, which was an excellent one, of just because I'm sad doesn't mean that I'm going to kill myself. And you're absolutely right. And we know that depression is really common among the general population and people with DD, especially right now in the midst of this pandemic. And so, I would encourage people to seek mental health providers, because they will understand that. They will understand, like, yes, you're sad and that's okay. Maybe they might assess for suicidal ideation and behaviors.
So how often do agencies then work with it? Because this was somebody who was running his own agency. That wasn't just like I was telling some random person or a friend on it. I know there's sometimes disconnects between the IDD system, but it was sort of like, I don't know. It was just one of those things to where in the service field, and I know that he doesn't need to be an expert. Maybe even just that being like, hey, I hear you, maybe you want to talk to, instead of like, like over just like, because I would probably talk to my parents every way, but it seems like he'd sort of, I'm sorry, I don't mean to make you, I know you said you didn't want all these personal stories, but it's related to the DD system. So hopefully I'm not.
Well, you're here as an advocate, right? So I think it makes sense that you're sharing this. So please don't apologize. I appreciate your perspective. And if I kind of switch gears, don't take it personally. Just know that I'm trying to get us through. So
I know. I think
what you're saying, Jason, is something that we see across systems, where it is hard for people to talk about mental health concerns. Even people that are trained to work with people really well, it's hard to talk about strong emotions and tough, uncomfortable feelings. And so I'm hoping that with presentations like these and some of the things that we're going to talk about a little bit later, we can start working towards decreasing that difficulty with mental health, and talking about mental health and when there's difficulty. So I appreciate that perspective. All right. So we talked about this a little bit, but again, it's just important to assess for suicidal ideation and anybody that's struggling with depression, because we know that one of the core symptoms of depression is thoughts of death. And so it's just something that even if you're not having them, somebody's going to assess for, because they want to make sure that you're safe and that you're going to be okay. That being said, if you say like, no, I've never thought about that, or maybe I had a thought about it, but I would never act on it, I don't have a plan, I don't have a way to do that, then that is kind of time for them to let it go and let you move on and manage what's happening in front of you and the symptoms that you're dealing with. And sometimes this is hard to do because individuals may have trouble expressing themselves. And so it's really important to make this as concrete as possible. And thinking about when you're asking children about these thoughts, obviously, if you don't feel that you're prepared to do that, or that you've been trained to do that, absolutely calling in a social worker or a mental health provider is really, really important. Even psychologists who are trained to do this feel uncomfortable doing this. Sometimes it's hard. It's not an easy thing to talk about. And so just know that your colleagues in psychology or social work are there to support you through that. And it's not something you have to deal with on your own. And then I do see a comment in the chat from Christy. Okay, so she's just talking about how organizations are trying to provide mental health training to better support people in those situations, which is excellent. And I think we could all use training in that area. Again, it's uncomfortable to talk about sometimes, and it can be hard talking about strong emotions, but it's really important. One thing that I wanted to share to kind of highlight why it's important to assess for suicide is this study that came out. It's a Danish study with 6.5 million people. So, you know, it's not in our country, but it was with a significant amount of people who had autism. And what they found was suicide attempts and deaths are more than 3 times higher among individuals with autism, and with significantly higher rates compared to the general population. And that is across all ages. So it doesn't matter if you're 10, 21, 30, those rates are a little bit higher. And unlike kind of what we see most of the time in the general population, where men are more likely to attempt a suicide, girls with autism are actually more likely. So just kind of thinking like, okay, if I'm working with an adolescent girl with autism and she's expressing some even just like passive concerns about depression, we really need to check in on this and assess for it. Again, maybe it's not there, but it's important to assess and then get your social work and psychology colleagues involved. And then obviously with anything, if you have an anxiety or mood disorder, whether or not you have DD, you're going to be more likely to attempt suicide. So just keeping some of these things in mind. You know, this is a tough subject to talk about, but it's important so that if we are seeing some of these behaviors or warning signs, that we dig into them deeper and get the right resources connected with our friends, our patients, our families, whoever it might be.
Well, I have a question on that data. Is that, so it's just for children? Does it track anything with adults with autism, men and women?
So it actually was with a wide range of ages. So not just with children. Yep. It was with, I don't remember the age range specifically, Jason, but I can look it up for you and send you the article.
And so, and so the results, even because it says girls to boys, is that it's just saying that because this is a children's hospital and it's relating to everybody, or was that data specifically for girls and boys who are children, and then the data for adults is something different? Or did they parse out the data even, or they just conglomerate it all? And I'm sorry, I'm sure you could send it in the article as well.
No, these are great questions. I mean, the specifics are important, right? And so for this was specifically around girls and adolescents with autism. The point that I was making in here, and I think that is because that is my wheelhouse. And I realize with this diverse group that maybe I need to expand that and bring in some more adult information. This study does have adults in it. And so I would be happy to share that with you also, that gives you some more information as well.
Yeah, because I think there's a couple of us who, me, myself, and I know Christy and I think Pat, who do a little bit more adult things. So sorry, not to.
No, it's good to know. It's very
Andrea,
helpful
I think. Sorry.
Yeah. No, it's great. And I love that there's such diverse perspectives here. I'm going to briefly talk about additional disorders because I really want to get to treatment. James has some really great things to show you guys. And I think that's kind of the important takeaway from these. So like not what these disorders are, but how do we make people feel better? So we also know that bipolar disorder can be mistaken or overdiagnosed in individuals with autism, just because there's some overlapping and similar symptoms. So maybe like elevated mood, rapid speech, excessive talking, those kind of things. So just something to be mindful of when you're maybe a provider looking at somebody who has bipolar disorder or autism, or maybe you're considering both of those. And then psychosis oftentimes tends to be overreported. Sometimes, depending on the language level of the individual, it can be difficult to diagnose because, again, we know this is something that's happening internally. It's hard to look at the behaviors of the individual completely and understand if they're having psychosis, because we need to know, are there voices that you're hearing or sounds that you're hearing, or are there things that you're seeing that aren't there? There are certainly behaviors that we can look at. So if someone seems to be zoned out or, just not there, or if their affect is really flat. So if their facial expressions are really flat, but again, those can overlap with different developmental disabilities. And so we just want to be really careful to not overdiagnose this and really consider the development of the person. I want to switch gears though a little bit and get into what I feel like is the fun part of psychology and talking about treatment. So James already touched on this a little bit, but when to intervene. And so I won't go over this too much, but really if it's causing impairment in your functioning in any way. So if you can't do the things you want to do or that you need to do, that's when it's time to intervene. So like James was saying earlier, if he was so anxious about this presentation that he called in sick, so he didn't have to do it, that would be a clear indicator that maybe he needs to seek help. Other things are if it's just causing you distress. So even if you're able to get through the things that you want and need to do, if you're feeling distressed in some kind of way, it's important to address it. If you're feeling isolated, if you thought about harming yourself, anything like that. And then I really appreciate Angel's perspective and like, okay, what can we do before this becomes a concern and something that we need to treat? And so there's a lot of strategies out there for health and wellness right now that we can implement proactively so it doesn't become a disorder. So I often will tell families, even if a child doesn't meet criteria for anxiety or depression, like let's proactively do these strategies, or let's proactively meet with a psychologist and look at this so we can start addressing this before it becomes a bigger problem. And I think that's some of the fun part of working with children, is that we can see some of these concerns come up early and address them early too. I'm going to briefly talk about different levels of care. So there's outpatient treatment, which would be like seeing a psychologist or, counselor or something like that once a week for maybe like 40 minutes or so. There's also intensive outpatient services. So this would be seeing a counselor or a psychologist maybe 2 to 3 times a week for a longer period of time. So maybe it's anywhere from an hour to an hour and a half. So one of the intensive outpatient services that we have here is called Regulating Together. And that is a class for children that have difficulties with emotion regulation. It doesn't matter your diagnosis. If you struggle to regulate your emotions, you're a good fit for that class. And it's 2 days a week for 90 minutes each. So that's kind of what that looks like. And then day treatment, which is also often referred to as partial hospitalization. And because in any field, we like our acronyms and our jargon, you'll often hear people say like PHP is an acronym for that, or for intensive outpatient, people might say IOP, those kind of things. But really, this is kind of like, instead of going to school or work, you're going to a hospital or a mental health facility to learn skills. That might be functional skills like taking care of yourself, but also mental health strategies to help yourself deal with the anxiety or depression or whatever difficulties that you're having. We actually have pretty great inpatient services here. So just curious, who all is familiar with our College Hill services? You can just raise your hand if you are. Yeah, and So we have, I think, 10 beds available in a neurobehavioral unit for individuals with co-occurring neurodevelopmental disabilities and significant mental health concerns. So this could be for individuals that maybe have limited language, have pretty significant behavioral concerns. But then we also have a unit where individuals who maybe are higher functioning and have autism could go and be a part of that unit as well. So just because you have a neurodevelopmental diagnosis doesn't mean you necessarily need to be in our neurodevelopmental unit, but we do have that facility available, and it has 10 beds. So most of the hospitals that I've worked across the country have about half of that. We also do crisis intervention. So really cool. I used to study in Colorado, and they were actually having mental health counselors go out with police officers to individuals' homes when there was a crisis. So specifically a mental health crisis, like maybe somebody was attempting to harm themselves or somebody else. And so that's a really cool new like national model that I think is going to start to be implemented more and more. And then this could also be like going to the emergency room. So if somebody is threatening to hurt themselves or somebody else, you know, calling 911 is always the good thing to do. And then that would likely end you up in the ED. And then we have residential treatment. This is actually fewer and far between, especially because I don't work with the adult population as much. I know of one really well-known residential treatment here in Cincinnati, but I don't think that we have a ton, and it's something that's not happening as much. But, you know, there are people that need long-term mental health services. And then we have our College Hill campus, which is wonderful and already has great services, but they're actually expanding, and they're expanding for people who have significant mental health concerns. And so that's really exciting for people like me and people who care about mental health, because like we've been talking about, it is really important. And unfortunately, there's still some stigma and lack of services that are available to people who are struggling with mental health. And so it was really exciting expansion that the Cincinnati Children's Hospital is doing up at College Hill. So I'm going to turn it over to James, and he's going to talk more about treatment and share some really fun videos with you all.
All right. So most of the treatment stuff that we'll be talking about today is behavioral or cognitive treatment, and less so about the medication. Though medication does have an important role in the treatment of different disorders. But kind of at the top level, it's this big, broad umbrella of psychotherapy, which is kind of any sort of behavioral or cognitive therapy related to treating a mental health condition. And this can fall under things like cognitive behavior therapy, which we see here is that next slide. It's the most commonly used form of psychotherapy. Could also be things like psychoanalysis or different sorts of acceptance and commitment therapies or things like that. So it's a big, broad umbrella term, but the one that we use most often and that has kind of the most evidence and most research behind is that cognitive behavioral therapy, which we'll talk about in just a second. There's other more kind of like strictly behavioral interventions as well. So ABA, or applied behavior analysis, is one that's often used for individuals and families with autism spectrum disorder. So lots of kind of controversy surrounding it, kind of within the research community and within the ASC community. But this is kind of the most empirically and research supported treatment for some of those behaviors. But there's other options as well. So things like Ruby Parent Training is a parent training group for children ages 3 to 10 with autism, and also some mild to moderate behavioral difficulties. So things like tantrums or noncompliance or things like that, where you're approaching those behaviors with the understanding that these children have autism. So your approach is going to be a little bit different. So even though This looks similar to other forms of parent training. It's also a lot of functional behavior analysis, which we've talked about a few times so far, really paying attention to what those triggers for those behaviors are, and how we can help manage those triggers to prevent those disruptive behaviors. You see similar techniques in behavioral parent training, which is used for children with ADHD. Kind of same thing, working with contingencies and reinforcement and helping with that non-compliance and reducing those disruptive behaviors. So lots of different behavioral options. There's also more kind of general rehabilitation interventions, so things like problem solving and self-regulation training. So really helping manage that or improve that flexible thinking, and how can we tackle problems before we get frustrated or upset. Maybe we break things down into smaller components to make them more manageable. Or in self-regulation training, really working on regulating those emotions. So one, being aware of those emotions, and then two, how can we maybe better control how those emotions ramp up. So things like using the zones of regulation. It's one of the techniques used there. So you're in like the green zone, the yellow zone, or the red zone. So that helps identify kind of what level of emotionality you're at. Okay, now we can work if you're in the yellow zone, let's work to get down to the green zone. So things like that, where you're becoming more aware of those emotions and how you can help regulate those with calming strategies or relaxation strategies. Trauma-informed care is another really important form of intervention for individuals, especially individuals within our population of IDD who are more at risk for experiencing trauma and abuse and things like that. And so trauma-informed care isn't any specific technique to address trauma symptoms or the effects of those trauma symptoms, but it's more so this general approach of being aware that trauma has effect on individuals and their behaviors and their emotions, and being wary of how we can maybe be adaptive to that, and provide services and support systems in a way that recognizes that these individuals have faced trauma or are currently experiencing trauma. And then lastly, there's that psychopharmacology, which is the use of medication to help some of these behavioral or emotional difficulties that can be seen. All right, so kind of most importantly, and Jason has alluded to this a couple of times over today and last week, that there's kind of this misconception that individuals with developmental disabilities are not appropriate for psychotherapy, whether it's because of their language functioning or their intellectual functioning or any of those number of reasons. But the truth is that they are appropriate for psychotherapy, and we can really have some big changes in some of these difficulties with some of these traditional psychotherapy approaches. We adapt them to make them more accessible to families and children, and make them more appropriate. But we can absolutely use these strategies to help with anxiety or depression or different behavioral difficulties. So as I mentioned, cognitive behavior therapy is kind of the big therapy that is most often used to help with these different difficulties. And cognitive behavioral therapy, or CBT, is really drawn from this idea that we have thoughts, we have feelings, we have behaviors, and all of these interact with each other. So your behaviors influence your thoughts and your feelings, and thoughts influence your feelings and your behaviors. And feelings influence how you act and your behaviors and your thoughts. And there's always these kind of bidirectional relationships. And so we're going to act on these things. We're going to change some of those behaviors. We're going to change some of those thoughts to help improve those feelings. And there's more and more evidence that these types of approaches work in individuals with IDD. Importantly, these approaches are working on identifying those thoughts and emotions that are driving the behavior. Oftentimes it's the behavior that's the reason why some of these things are so impairing and so or interfere so much with day-to-day functioning. And so the goal is to identify and really conceptualize how those thoughts and emotions interact to drive those behaviors. There are some challenges to this, as we'll talk about in a little bit, that we are able to kind of adapt things to help address these challenges. But there are some challenges, and kind of the main of which is that it really relies on this ability to self-report your thoughts in your feelings. You need to be able to describe the thoughts that you're having, so those thoughts can be targeted with, changing more negative or unhelpful thoughts into more positive and helpful thoughts. That depends on you being able to describe what those negative thoughts are. Same thing with those emotions. You have to be able to describe how you're feeling and how those emotions are maybe impacting the way that you're thinking or the way that you're behaving. And so because of that, to work with individuals with IDD may need some modifications and some adaptations, which we'll talk about, I think, on the next slide. Yep, there we go. All right, so this is most often what we use in kids. Dr. Smith and I work here at Children, so that's our target population, but these same strategies are useful with adults as well. You want to make sure you're using kind of simple, concrete language, not using big, fancy terms. So for example, when Dr. Smith and I do our Facing Fears group, we're not talking about anxiety or cognitive behavioral interventions. We're talking about worry or fear, or you're scared. And we're going to use some relaxing behaviors instead of some positive adaptive relaxation strategies, just kind of simplifying things a little bit, keeping it nice and succinct, giving that information at a slower rate. So it allows people more time to absorb that information and think about it and really digest it. Having a more structured therapy session, oftentimes, there's this kind of conception of therapy as you lay down on the couch and you just talk about your thoughts and feelings to the doctor for an hour, and then they say a couple of things and they push you on your way. That's not how therapy works. We're going to have structured, manualized treatments where we're going to do X, Y, and Z today and work on those skills. And then tomorrow we're going to work on A, B, C. And the next day we work on 1, 2, 3. So having that structure, that also helps with some of the challenges that we talked about earlier, especially in individuals with autism, having that structure and that routine, keeping it consistent. Lots of pictures, lots of videos, lots of role playing. You'll see my pictures here. These are my actual worry and helper bugs from Facing Fears. So having these kind of visual concepts of what our worry is. So in Facing Fears, our worry isn't us. It's not who we are. It's a worry bug who's kind of sitting there and talking in our heads and telling us these worrying thoughts, and then using a helper bug to help change those thoughts into positive thoughts. So using that kind of analogy through pictures and videos is helpful. And also using those real life situations as well. So it's directly applicable to what that individual is experiencing and the challenges that they're facing. So it is concrete. You're actually teaching them, in this situation, you can do X, Y, or Z. All right, other things that we want to consider as well are things like open-ended questions. So instead of maybe asking a leading question, like, did your stomach hurt and do you feel dizzy when the fire alarm went off at school? Having it be more open-ended. What did you feel? How did your body feel when the fire alarm went off in school? If the kids may be really afraid of the loud noises of fire alarms, or when you saw that dog, what did your worry bug say? And letting them kind of describe how they were feeling in their own words. Also using that didactic education for things that are more broad or more abstract. So that didactic education is structured. It is kind of a one-on-one teaching where you are moving through a concrete list of steps, doing lots of check-ins, making sure that they're understanding what's being discussed, and using questions to help with that as well, to check in and see if they can say it back in their own words. Families and caregivers play a huge role in treatment for our population. Facing Fears, I know I keep bringing that up, but it's a family group. So it's parents and children come in. We spend half an hour together as a full team. The next half hour is we split up. So the kids go with some providers, the adults stay with the other providers. So everyone is involved in the process. Making these skills more generalizable and offering materials in a way that they can be used flexibly and adaptively in different situations. And then just lots of repetition, lots of extra time and opportunities to practice those skills and really work on using those skills in those moments.
So James, the next slide is sharing an example from Facing Your Fears. For the sake of time, do we want to just do one? We have relaxation and exposure.
Let's do exposure.
Oh, that's what I was thinking. Nice. All right. So give me a second while I pull this up because we all know how I am with technology. James, do you want to kind of give them
Like an overview.
mhm.
Yeah. So if you remember way back at the beginning, I talked about how avoidance is the most common coping strategy and how it's really effective in the moment because it allows you to not address that fear. It's not good in the long term because it still maintains that fear. You never learn that fear maybe isn't something to be worried about. So the way you address that is through exposure. So you don't start off doing the first thing or the big thing that's really scary. So I think this one is talking on the phone, if I remember. So let's say you're really nervous about calling someone on the phone because you don't want to say the wrong thing or whatever. We're not going to do that as our first exposure. We're going to start at the bottom, do something that's a little bit easier, maybe not quite as scary. And then we're going to do that and see how we feel. And maybe that wasn't so bad. Look, I did that. I was successful. I faced that fear. So I'm going to try the next thing. It's a little bit harder. I'm going to call this other person or I'm going to call this other number. Okay, I faced that fear now. That wasn't so bad. So I'm going to do the next step and make it so you're progressively making it a little bit harder until eventually you're at that top fear. And so this is a little video that shows how we do that in our group. The acting is not phenomenal, just as a heads up.
Greetings. In our segment today on Facing Your Fears, we are going to help you conquer your fear of talking on the phone. We will introduce you to Josh, who is afraid of talking on the phone. To help Josh with his fear of talking on phones, his friend Jake will coach him through the steps to success. Let's begin. Josh will start with step 1, answering the phone when his grandma calls.
Okay, I'm ready to face my fear of talking on the phone. I'll start by answering the phone when my grandma calls.
Say, I can handle this. I want to get over this fear.
I can handle this. I want to get over this fear.
Or are you on your stressometer?
My head is starting to hurt. I think I'm at about a 5.
Take a few deep breaths. That will help you face your fear. Say answering the phone is no big deal. Your grandma must be calling to tell you something.
You're right. Answering the phone is no big deal. I'll answer and see what my grandma wants. Hello? Okay. See you later, Grandma.
Say I did it. Good for me. I answered the phone.
I did it. Good for me.
So that's an example of one of the smaller steps that James was talking about. And then I'm going to try to fast forward so that we can get to maybe one of the bigger steps and you can see how the exposures progress.
You'll see lots of visuals. So they have that stress-o-meter. That's a visual indication of how they're feeling, like the green, yellow, red. It has numbers on it that help them gauge how high up they're feeling. Lots of simple kind of short things. Let's take some breaths. Let's use a helpful thought.
Okay, page 6. Got it. All right, see you later. Bye. Woo! I did it! That wasn't too bad. I think I'm at a 3.
Now Josh is ready to do the final step. Call a store and see if they have a DS game drawn to life.
Now it's time for my final step. I'm going to face my fear of talking on the phone and call a store about it and call GameStop about a DS game. My worry is going up to an 8 this time. I don't want to call.
Say I can do this. It's just a false alarm. You need to calm yourself down. Tell yourself you can do this. Take a few deep breaths and get ready to call the store.
I can do this. This is just my body's false alarm. Here I go. Hello, I was just wondering if you have the game Drawn to Life. All right. Okay, thanks. Great job.
All right, so as you can see, it was very structured, right? There's a whole process. First, we do our stress-o-meter, then we do our relaxation strategy, and then we do our helpful thought. Then we do that exposure, we face that fear, then we look at our stress-o-meter again, and we did it. So very structured. When we show these videos in our treatment group, we do lots of check-ins with the kids after we watch them. So we'll watch a section of it. Okay, what was his helpful thought? What was his relaxation strategy? Did the stress-o-meter go up or did it go down? Did he face his fear? Gain that kind of check-in and that buy-in. Parents tend to love the videos, the kids not so much, but my favorite's the dog exposure because the dog just sits there and wags its tail the whole time.
And if you've never seen an exposure in person or have tried this yourself, they're really fun. I mean, you guys might be doing mini exposures all day long and you just don't know it. You're doing hard things, whether it causes anxiety or stress, whatever it is, because there is a sense of achievement when you do something hard like that. So it's a really fun group to be a part of.
It's amazing to see their progress. You'll have a kid come in the first week who is absolutely terrified of something, and then by the end of the program, they have themselves on video doing that thing that they were so terrified about. And see the parents and the children are just so proud of themselves on the work that they do.
And the dog was very proud.
Yeah, the dog is the best actor of the whole series. She's so well behaved. Right,
really
so in addition,
cues.
Yeah. In addition to a lot of these behavioral interventions that we were just talking about, medications do have a role as well, as I mentioned, but they shouldn't be used just by themselves to treat these conditions. So if you remember, last week I talked about the biopsychosocial model and how there's lots of different factors across those different domains that impact physical health and mental health. The medications are only targeting that one domain, that bio domain, those physical aspects that the medication is treating. But again, those are not the only contributing factors. So it's important that we use other skills and strategies as well. When we are talking about medications, we want to make sure that we're also taking an interdisciplinary approach. So for example, Dr. Smith and myself and the other psychology trainees, like we don't receive training in medications and the side effects and the contraindications for when you should use one medication or not the other. So then we're going to be working with people like Abby or Nicoletta or Elodie, who have that training to address the medication aspect of it. And then we're focusing on that behavioral or cognitive aspects as well. Shared decision-making is an important part as well. So that's involving the family and the individual themselves in that kind of decision making tree for what treatments to pursue or what strategies to use. And then other organizations have resources as well for individuals and their parents. So Autism Speaks has a medication decision aid. It's like a 20-page kind of pamphlet or booklet where you go through a series of questions about, okay, what are those behaviors that you want to address? Okay, these are the behaviors that we can effectively treat with medication. Do any of these behaviors fall on that list of things that you want to address? Okay, now here are some benefits of medication. Here are some risks of medication. Choose which benefits and risks are important to you. Okay, now you have all this information. How strongly are you feeling towards one or the other? And so it kind of walks you through the process of outlining or outweighing all of your options.
How do you also listen to somebody with when said there's medication side effects and stuff? I know there was a medication that they gave me once, which the doctor said I couldn't have that side effect, and then it turned out the medication was black boxed.
So how do we address
Yeah,
where
I
people
think
come to
there's
us with side
sometimes,
effects?
with families or something, sometimes other, even individuals themselves, when a family tries a medicine and then they're saying that, like, I'm feeling this side effect or something, and they're like, oh, well, that can't happen. I mean, and helping people also find that doctor who's going to work with them. Because I've had, for medication doctors, obviously somebody who said that's not possible. And then figuring, and then when we looked it up, it was black box, and then other doctors who are more willing to work with, into like giving those families, but also giving the training to some of those doctors or things about being able to listen to the person for some of the side of, if they're feeling things, and checking in with them as well. Sorry, I don't mean to derail.
No,
No,
Jason, don't apologize. I'm going to
apologize.
take this one if it's okay, James.
Yep.
Because for James and I, we would actually absolutely listen to patients and families regarding that. However, we really need them to go to their medical team to talk about those discussions, because that's not our area of expertise. And I think that's really important, and kind of understanding your limits and where your expertise lie. And so I really want to lean in on some of our developmental pediatrics fellows, and see if they have some good answers for us about this, and see if the shared decision making models being discussed in your medical school, or what that looks like for you all.
I will say I wasn't really taught about shared decision making like in a formal way. Except that that's a lot of probably what we do on like family centered rounds in pediatric like residency training is probably a lot of shared decision making. We just maybe now they've incorporated, but we never really called it that when they were training us in that. But I mean, I think the biggest thing is kind of to ask the family what their priorities are. Often families will come to you with multiple complaints, and you just kind of have to see which one is the biggest issue right now. Because if you try and do too much at one time, you're not going to know what's working. And I think explaining that to families, like we're not disregarding some of these symptoms, but we do have to introduce things one by one and know what's working and what's not. And that makes, I think, shared decision making a little bit easier, is like just being very upfront about why you're doing what you're doing and why we're choosing to focus on something rather than something else. But I don't think it was formally taught. I don't know if Nicoletta and Elodie had a different experience.
Or can you speak to maybe what happens when somebody comes in and they say that they're having this side effect, and maybe how you would handle that as a provider, and what that kind of looks like, and maybe if somebody's not happy with the interaction that they're having with their provider, what they should do?
Yeah, I mean, I think when someone's having a side effect, you have to take it seriously. Even when it's one that's like less common. I think it's hard. You have to really make sure we have like a concrete, like, when is the side effect happening? How often are we seeing it? When, when did it change? Is it with a dose change? Is it with just starting the medication? Did we start the side effect 2 months in the medication, so we don't actually think it's a side effect, but it could be something else? So you kind of have to tease out, but I think always take it seriously. And usually I assume it's a side effect if that's what they're saying. And honestly, it's really like, if they're not feeling good on it, then there's less buy-in. So they may not want to take it. And I don't want them to stop it on their own. So then I do think we need to consider switching medications or lowering the dose. And I think you have to present a couple options, because we need their buy-in before we make a decision. And we need to know kind of what they can tolerate and what they feel like is not going to work.
Yeah, so it sounds like, sorry,
No, go ahead, Jason.
Because I remember the specific situation. I mean, obviously, there's some ways I like to code things and put things in particular orders, but I became really obsessive about some of those things, and it was correlated after that sort of medicine. And they're like, "There's no way that could happen," even though, I mean, that sort of thing of becoming less functional became after that, and hasn't usually been that bad. Has ever been that bad since then. It was just sort of one of those interesting things, and it being like, you couldn't happen. This could you. I don't know. I mean, sorry.
No, I think that's important too, is like not downplaying it. Just because we haven't seen it doesn't mean it doesn't exist. And like the black box warning for like SSRIs, for example, came out a little bit later. And that was something like, that's an important thing to consider. And we know that there's a lot of factors that led into that black box warning, but we also know that that is something we need to take really seriously. And even if we've not heard of it before, then we need to be taking the patient at how they feel whenever we give a medication, because otherwise they're going to stop it. And that's dangerous. Like, we need them to tell us when things are just not working. Yeah. So I'm sorry. It's not a perfect science, and we're just now figuring out the whole shared decision making, because we've been very paternalistic in the past in medicine.
No, we found out it was, no, you're right. So how long does it take? Because we found out it was black box while I was still on that medicine.
I mean, it depends on the medication. It depends on the side effect. For the SSRI warnings, we usually see that in the first couple weeks. But like there are, I mean, at any time, and we know that there's a lot of other factors that lead into that black box warning. But yeah, we typically see it earlier, and side effects typically come on early.
Would a doctor generally, if they didn't, like it came out and then later it gets a black box warning, would they be notified on that? Or is that something that, they might not know if it's something they were using before and then?
Yeah, I mean, I'm not
trying to understand.
No,
not to be critical or.
Because I've only been at this for like I started medical school. It's been like 4 or 5 years of me actually practicing as an MD, but as far as I'm aware, that you get notified by the FDA, but not necessarily. I mean, they're not tracking what you're prescribing. So you would have to be on the lookout for that. You have to be educating yourself, which is why we have CMEs, like continuing medical education and things like that. But no, you wouldn't necessarily get notified of that if you have patients on SSRIs or whatever.
Well, Abby, thank you so much for letting us put you in the hot seat. I really appreciate your perspective as a medical provider. And that is a really important part of mental health is for a lot of individuals, when their symptoms are appearing, really a combination of the medication and the therapy James was talking about. So Abby, thank you so much again for letting us pick your brain a little bit. We're going to move on from medications and talk a little bit more about systems issues, just because I know you guys have asked about that already. And I like to give you all some hope about like what we can do moving forward. We know that there's mental health disparities that are happening in our country, but how can we address them? And what are small actions that we can take? And what are some big actions that we can do? So the interesting thing that I think a lot of psychologists are trying to kind of understand the silos between the mental health system and the IDD system. So oftentimes in the mental health system, you'll see treatment as short term. So if you have a really good psychologist or counselor, they don't want to see you for your entire life. They want you to have treatment goals, meet those goals, and then kind of graduate from them. Oftentimes that might require like a check-in every now and again, or, maybe when there's stressors that come up, going back to them for a short period of time. But really the idea is to meet goals, where oftentimes in the IDD system, services and supports are over the lifetime. So your providers are with you for life, like your developmental pediatricians or the folks that you work with in DDS, like your case managers, things like that. And so it's a little bit of kind of a reframing of what these different services offer and how they kind of play a role in people's lives. And then a lot of times in the mental health system, you know, we are thinking of individuals as like clients or patients. But in the IDD system, they're thinking about individuals as self-advocates or consumers. How do we get them to really find out what their strengths are and how to lean in on those and meet their potential and grow to the best, you know, Johnny or Jane that they can be. And then, you know, I think really importantly is that sometimes these systems don't always speak to each other. And I think that's where people like James and I are trying to bridge the gap, because it is really hard with mental health in general, and the stigma that's kind of out there. And then when there's additional disabilities, it can be a little bit tricky. And sometimes the IDD system and the mental health system don't speak to each other in a way that's really helpful for individuals with IDD. So these are kind of the big system levels differences in how we're thinking about it from like a mile high view. And at the same time, we know the need for mental health services is very high. This is among the general population and individuals with neurodevelopmental disabilities. I know that there's a lot of new research out there showing the effects of, you know, the pandemic and things that have been going on recently. And right now, I think that mental health is a crisis in our country and something that we need to dig in a lot deeper. So research, I think from last year, I don't know how current this is, but this is from 2020, was saying that only 1 in 10 children and adolescents with co-occurring mental health disorders receive specialized mental health treatment. And so that's a really important disparity because we know that these people are struggling and that it's likely causing them impairment, but they're not getting the treatment and services that they need. And so again, some system level issues that we need to think about. There's barriers to services. So like the system's not talking to each other. Also, who takes responsibility for the advocate or the patient? Is that the IDD system? Is it the mental health system? And I think in general, there's a lack of awareness about services that are available for mental health. And I think there's a lack of understanding about individuals with neurodevelopmental disabilities among mental health providers. So really, so many people who are counselors or psychologists can apply the skills that they learned to individuals with and without neurodevelopmental disabilities. But there's something that feels hard about that, I think, for some providers that can get in the way of them being able to do that. And I think, again, it's just about decreasing that stigma. So I did a presentation recently with our behavioral medicine and clinical psychology division, just sharing about treatments for developmental disabilities and individuals specifically with autism. And the feedback I got was like, oh, well, this isn't so different than like what I do. You guys are using all the same principles. Maybe you're modifying things a little bit, but like I could do this too. Obviously, you know, for James and I, our services might come in when an individual is a little bit lower functioning or really struggling to express themselves or have limited language skills. But oftentimes somebody with autism that's higher functioning can be seen by a provider, even if they're not specialized in neurodevelopmental disabilities, because those same principles and strategies apply to everybody. So really, again, it's just about increasing awareness about the interaction between these two and mental health and neurodevelopmental disabilities in general. So not to make you all feel so bleak before we end here, because there is hope, there's things that you can do. So, you know, talk to individuals about what you heard today and ways that you can become involved in the mental health system. Maybe that's advocating for yourself. Maybe that's figuring out how you can work with your colleagues in social work or psychology, whatever that might be. And then really importantly, thinking about screening and assessment. So thinking about those behaviors that we talked about earlier that might signal that there might be a mood concern or a anxiety concern, and how that might look a little bit different, and that just because it might look a little bit different doesn't mean it's not something that we want to dig into. And then, understanding the systems and barriers is really important. Advocacy. I think you guys have DD Advocacy Day coming up, or did that already happen? It happened. Yeah. Okay. Oh man, I missed it. Darn it. Well, I don't know what did you guys talk about this year? I'm curious. Did you have a chance to talk with your legislators at all?
We mainly had to talk to representatives, so we were supposed to kind of complement the fact that they passed that House bill with changing the language.
Okay.
Updating the language. And then there's a few of us that are on a specific SCBM group that talked about UC Health, the new clinic.
Nice.
Centers.
Very cool. All right. Well, I hope that felt manageable for you all to do, because you can do those same things with mental health. There's a lot of mental health initiatives and funding being poured into those initiatives. So like I was saying, the one in Colorado for the crisis intervention, where they're equipping a police officer with a mental health provider to go out if there's concerns about self-harm or wanting to hurt somebody else because of a mental health concern. And so those kind of things can make huge improvements, and took a lot of time for individuals to really advocate for that at a systems level. And then just thinking about things that you can do on a smaller level every day, because sometimes these system level things can feel really big, is, not being afraid to talk about the hard things, because sometimes when we stray away from that, we might lose rapport with somebody. So if somebody's saying that they're feeling really sad, saying, I'm sorry, that I know that must be really hard. Tell me more about that. What's your experience like? And really digging into that and being comfortable with being uncomfortable. And then knowing when to, refer to your social work and psychologist colleagues. Again, identifying the triggers, like the behavioral triggers that we see, that maybe somebody's not telling us I'm sad, but we're seeing changes in their baseline functioning. So we're seeing that they're sleeping more, or that they're eating a lot less and losing weight, or we're seeing that they're super irritable and we're not sure why. So thinking about those things. And I think, Jason, I appreciate your perspective, because I think what you shared with us throughout the presentation is that it's important to work alongside the individual that is having difficulties with mental health, and really make sure that we're figuring out what works for the patient or person with a mental health concern and what doesn't. I think Abby highlighted so well, like, if this person doesn't like the medication, they're not going to take it and they're not going to buy in. So why are we even going to do that? So thinking about really listening and getting that person's feedback. And then just like we did today, and Angel brought up earlier, teaching those coping and self-management strategies. So what are things every day that I can do to help reduce my stress? And James and I preach this a lot in Facing Your Fears, but practicing things every day, even if you're not feeling stressed or anxious or sad, is really important, because we know when you're feeling overwhelmed or sad, it's really hard to pull those things out and want to do them. So you have to practice them when you're just in your typical mood, so that you can get really good at them and they become easy, because a lot of these things aren't easy. Like I was saying earlier, I find my mind wandering all the time when I do breathing exercises. So it's really important to practice. And it seems like such a small, silly thing, like, oh, I don't need to do that, or I skip that, but it really can make a big difference. And again, the Calm app is free for individuals that work at the hospital. And then just some take-home points for today before we, oh no, you guys you're supposed to end at 2:50, right? Oh, so why don't we've kind of talked about everything. Here's some helpful resources that will be on the website that you can always refer to. NAMI is great, or NAMI, I think is how you say it actually.
Yeah, it's NAMI.
NAMI, thank you, Jason. They're wonderful. They have a lot of great resources. but I want to make sure that if anyone has any questions that you have time to ask those. And for those of you that need to leave and take a break, please know that's totally fine. I know we were supposed to end at 2:50 so that you guys can get a little break before your next class. So I will stick around. James, also, if you need a break, that's okay. If you want to stick around, great, to answer questions, but we'll be here. And thank you so much for your time today. And Christy, I think Christy left. James, can you send me Christy's information so that I can reach out to her?
Yep, I can do that.
Okay, awesome, thank you. And Donna, it was so nice to see you. I've heard so much about you from Amanda.
Oh, thank you. Nice to meet you too. Go away.
Oh, is that Maddie? I've heard
It's
about
Maddie.
you too. Hi, Maddie.
She's got home from work.
Oh, very cool.
Also
All right.
going to national.
All right, well, if nobody has any questions, I will stop there and hope you all have a great day and have a good next session, whatever that is. Take care.